just introduce our next speaker, who, not coincidentally, is Anna's supervisor for her MRes, Sunil Bhopal, who is one of our academic clinical lecturers here at the University of Newcastle, is also an alumnus of the London School of Hygiene and Tropical Medicine, where he took his PhD and still holds an honorary appointment there. And is very active in the field of paediatric public health, particularly in resource-poor settings, and is a powerful advocate for child health everywhere. If you want to go to follow him on Twitter to see how prolific he is with his outputs. So without eating up any more of anyone's time, I'll hand over to Sunil for his talk. Thanks very much, Sunil.
Thanks, Stephen. Thanks very much. Brilliant. Right, let's get going with the screen share. Anna, it was great to hear about your work and our work. What fun. So I'll try and finish on the kind of allotted time, and leave a few minutes for questions. I mean, I think, when I was reflecting on this talk, I thought, well, COVID-19 in children, not just in the UK, but globally, where are we? Not quite sure. Where are we going? Not quite sure. Are we any more certain than we were in March? And I think there are some certainties, but there are many unknowns too. So I think today's presentation is posing questions, raising ideas, and very few simple, straightforward answers, which those of you who've been following the pandemic, which I imagine is most of you, will appreciate, is essentially how it's gone throughout. It's been a bit of a funny time, I think, for me, on a personal note, and feel some parochialism has crept in with the borders closing, and colleagues around the world having to stop their fieldwork of various types. So I've done a lot more work in the UK, and I'll kind of reflect on that, and we'll see how it may or may not connect to what's happening elsewhere. So this is kind of back in April with Al Ainsley Green, a really short and pithy letter to The Guardian, asking the question, given the appropriate governmental prioritization of the needs of adults and particularly the elderly in danger from COVID-19, who is responsible and accountable for the best interests of children and young people? And we were talking about the UK, and we were saying there seems to be a stark lack of political focus and absence of public discussion on the effect of COVID-19 on their lives, children and young people's lives, across health, education, social care, justice, and poverty. And as we'll go on to discuss, I think that's a fair representation of how things have gone over that period. The political focus did increase, particularly around schooling and education, which was absolutely wonderful to see. And I'll show the front page of the Times newspaper, which many of you will have been involved with. I think the paediatricians stood up and did a good job in June to get our children back to school. And it all really started from this, which is COVID-19 in 7 high-income countries, where we had the data at that time. There were a couple of BMJ pieces and a public health piece, and we update a table here at tinyurl.com/childcovid, where we looked at UK, USA, Italy, Germany, Spain, France, and Korea, and really said, okay, what is happening here? What do we know? And I've just pulled out the latest figures, which are to the end of August. In those 7 countries, there were 111 deaths from COVID-19 in 0 to 19-year-olds, 14 in the USA, because they report their figures differently. And this was compared with many, many more deaths from all causes, tens of thousands from all causes. These include neonatal deaths, as you'll all appreciate. That's a much greater number than older children. But even if you strip them out and start to chop it in various ways, what we're seeing is that COVID, very fortunately, one of the few silver linings, you might say, of this pandemic, children have not been drastically affected by the direct implications of the virus. So, and here we are just showing it in Spain and France. And these are the sorts of bits of epidemiology that we were doing early on back in March, April. This is from the INED group, demography group. And you can see here, you're seeing the deaths from COVID much greater up in the 70, 80, 90 pluses in both France and in Spain. It's not the same in men and women. And again, really unpicking this has been a interesting challenge. But context is key. So when Stephen asked me to think globally, well, okay, let's expand outwards from the UK, Europe, and beyond. And well, what are the differences between different countries? Well, we'll talk about this today, but certainly we've heard about the rapid public health response from Daisy in the Gambia. We know about very early border closures and that have contributed to various countries being able to keep their case numbers low and their hospitalization and death numbers low. Also, massive experience in public health responses. So public health systems that have been set up to deal with other diseases kicking into place. Pre-existing immunity, this has been very controversial, along with many other aspects of COVID discussions, but more and more evidence now about pre-existing immunity to SARS-CoV-2 in various populations, including children and people living in various countries. And then age, and age is absolutely crucial. So for anyone that needs a reminder, if we look down on the bottom right or anatomical left for a medical audience, the United Kingdom's age pyramid from age 0 up to 100 on the y-axis, and you can see it's kind of like a thin stick or something. And if you look at Uganda here on the top left, or Botswana, or the Gambia down here in the middle at the bottom, we can see just what a vast number of a proportion of the population are younger, and it's really, really crucial to understanding what's happened. However, the world is not simple. Everything is complicated. So here's Japan up here on the top right. Japan has an even older population than the UK. Why? But Japan has not had the sort of pandemic that the UK has had. So why is that? I'll just leave that hanging. So the direct effects of SARS-CoV-2 on children, what we've seen here in the Northeast has been largely mirrored around the world. It's been a largely asymptomatic or mild illness, particularly in those youngest of children. So I think once we get up into teenagers and beyond, we are seeing differences, particularly the older adolescents in the United States have suffered, particularly those from minority populations, minority ethnic populations. So again, not a simple picture, but largely, I think it's reasonable to say, particularly in young children, overall mild illness. Many in this audience will already be familiar with PIMS-TS, an important inflammatory syndrome that has affected small numbers of children very badly. And here's a paper from India comparing, actually, it's quite nice, I thought, comparing Andhra Pradesh and Tamil Nadu, two Indian states, to the United States. So the population age distribution, fairly similar up here in A, the reported case and age distribution fairly similar here in B, and you can see the mortality trend by age down here in E. Again, fairly similar, with just greater numbers of deaths in the USA compared to those Indian states, but going up in similar ways. So we're not seeing vast differences in how children are directly affected by this virus. But, and those of you that that I've met in person over the last few months will know that I've been banging on about this. The indirect impact on health, nutrition, education, child protection, social welfare has been vast. That's here in the UK, that's in Europe and around the world. So here's a modelling study from the Lancet Global Health with early estimates of the indirect effect of COVID-19 pandemic on maternal and child mortality in low and middle income countries. And there are three scenarios show between 250,000 and 1.15 million additional child deaths based on reduction of health coverage and wasting alone. So that's a 10 to 44% increase in mortality across 118 countries. So really, really stark figures coming out fairly early on in this pandemic to remind us that a singular focus on the virus will negatively disproportionately affect children. There's a particular risk from suspension of vaccination programs, and as paediatricians, I think we could all be reasonably described as being pro-vaxxers. So for each COVID-19 death averted through the social distancing policies that led to suspension of I think the highest count I saw was 70 vaccination programs around the world. That's routine vaccination programs, 84 deaths from from childhood illnesses that can be preventable childhood illnesses for each COVID-19 death averted. And the figures from Lancet Global Health, different paper, 80 million infants at risk of contracting vaccine preventable disease, and the benefit risk ratios for sustaining vaccination programs, absolutely massive for vaccinated children, for their siblings, and even for their parents and other adults who live in their households and in their communities. So I don't think it's controversial to say that as paediatricians and as child health advocates, we would want vaccination programs to continue. The logistics of doing that, the policy and political dimensions of doing that, not straightforward, not simple, but there's been amazing advocacy from UNICEF and WHO and others to get these vaccination programs going again. Here's another example, nutrition, and Stephen did ask me not to lower the tone by just giving bad news the whole time, so I'll try and I'll try not to do that. So nutrition. This is from Zulfi Bhutto's group. So just thinking about ways in which the COVID-19 pandemic might negatively affect child nutrition and growth. So this idea of basic risk drivers, including increase in inequity, inequality, and diversion of spending away from these sorts of aspects of the health and nutrition system. Underlying risk drivers, so income and resources, so thinking about socioeconomic aspects, including social safety nets, leading to poor feeding practices and food insecurity, restricted health services, and unhealthy household environments. And you can see as this graphic moves onwards, we're talking about compromised maternal and child nutrition, leading to stunting, wasting, underweight, SGA, and micronutrient deficiencies. And then we can go further. So we've talked about health and nutrition. What about schooling? Well, here, like I say, here's the Times front page, 18th of June, 2020. I was absolutely just so proud of what we did as paediatricians here in this country. Doctors demand schools reopen. They didn't reopen in June or July, but I think that pressure was really key. Here's a follow-up letter that many of us in the Northeast started and followed through. And here's little quote: "We built Nightingale hospitals. Where are our Nightingale schools to save our children?" So a real sense that something was going wrong here. And I'll just show you a little bit of data from around the world about school closures. So if we look here, if we go back to January the 22nd, 2020, schools were all open because we all believed in schooling. We all thought it was a good thing, and there was no reason to have them closed. And as we go along, you can start to see that already by kind of 21st or 30th of January there, we start to see some schooling closed. And you can see that in East Asia, spreading down through the Pacific Islands. And then the first school closures there, 3rd of March in France, Italy, United States by the 11th of March. Very rapidly by the 19th of March, you can see this graph turning red. more and more red by the 26th of March, including United Kingdom. Little pockets of green and orange start to get filled in with red. More red, and then we start to see a bit of orange again through May, and things start to open up a little bit and start to open up through June. And you can see Southern Africa now getting a little bit more orange. You can see some yellow coming in, and then some blue and green again through August, September, October. And we are now into November. I think it slightly loses some data there, but if we go back there, I think the picture starts to be a bit more positive. So possibly some progress in this UNICEF tracking the situation of children in COVID-19 work has been really amazing to watch. And here's UNICEF's Henrietta Fore, Executive Director. The longer they stay out of school, they may never return to school. And for many children who are on the move, let's say coming out of conflict, they don't have a school to return to. So if we want that other half of children returning to school, we're going to have to be very proactive. And I think that's been really key to this, is thinking, okay, well, if we're going to do distance learning, how do we do it? Which groups can't access this? How do we avoid exacerbating inequalities? Child protection systems, I mean, you can go on and on, but essentially from that amazing UNICEF dashboard, you can pick up changes to child health and well-being systems around the world. And this is reduction in child protection systems in those countries that are not grayed out. So really huge impact on children and children's services around the globe. So the challenge is immense. And this is us writing in the, it was a joint statement that we put together between the International Child Health Group and the RCPCH, which ended up going in Archives of Disease of Childhood. And we said that the burden of indirect consequences of the pandemic will fall disproportionately on children, but we are alarmed at how little attention their needs are receiving. And it was really great that when we put this together, Sue Broster, the RCPCH Global Chair, and Russell Viner, of course, our president, were both willing to sign up to that. So the three of us signed a joint statement, and then this one we put together in the name of our groups. So why is it so tough? Well, Richard Cash and Vikram Patel asked in The Lancet, has COVID-19 subverted global health? And they asked the question, is it, well, they actually said that given the history of global health and the importance of and where global health comes from, it's not that surprising. But they argued that we've prioritized the conditions of the high-income countries, and we've asked other countries to follow suit. I think some of this is a bit controversial, but I'm putting it out there. People will have their own views, and I'm not sure. And so what next? Well, I mean, this is extremely tough. Countries need to manage supply of healthcare, maintenance of resources in maternal and child health, averting reduced demand, which we've seen hugely here in the Northeast, 90% reductions in A&E attendance, for example, socioeconomic circumstances, and avoiding the exacerbation of inequality. And for those that are interested in the ICHG, as well as, of course, our local group PINGs, there's the ICHG details. I was a convener until a few weeks ago, and I've handed over now to Delandev Kumar from UCL, and people may have been doing the RCPCH online conferences, and the ICHG session is this Friday morning. So there's the details down there if you're interested. And the question is, where do we go from here? So no right answer. The technical and the biomedical is not going to be enough. It involves value judgments, policy judgments, political decisions. And I think I've put NB vaccine because I just thought, I'm not sure if people have been following the vaccine trials, but I've been studying them quite closely for an upcoming paper and looked at all of the phase 2 trials so far, which have reported, none of which enrolled children. And you'll have seen that there's been decisions and discussions about vaccinating high risk people first. But there are increasing calls that perhaps children do need to be vaccinated against COVID-19, particularly if we're trying, depending on what the strategy is. And Marika Nielsen from Liverpool and I wrote this piece about vaccine hesitancy in low and middle income countries and potential implications for the COVID-19 response. Really very, very cautiously saying COVID is very fortunately not a disease that has caused severe disease for children. So any sort of disruption to vaccine confidence around other vaccinations for children would be, should be mitigated against, and we want to avoid potential disaster to the other vaccination programs. The importance of context, particularly around lockdowns, particularly around intensive care and ventilator capacity, and around the vaccine. There is now a transition as we come in November to what people are calling a new normal, but there's a considerable time left to run in this pandemic. It's certainly nowhere near over. The collateral damage for children is considerable and ongoing. And as we move to this new normal, we call for a re-strategizing and reprioritization. And I think a refocus on the child rights agenda, because I think in a period where things needed to be done very quickly and appropriately, choices had to be made to do as much as could be done to mitigate this major COVID-19 disaster. Child rights was not a frame that was really used by governments around the world, and hopefully we can start to think about how to reintroduce that important way of thinking. So that's what I have to say about this topic, and I'll hand back to, it's Ben, isn't it?
Thanks very much, Sunil. That's a fantastic talk, as ever, that you give. Just got a couple of questions. One, just some advice from you. So, if going back to your Twitter feed, perhaps around that June and July time, I think the audience here, would agree with a lot of the points that you made on some of those Twitter feeds, and I think it did raise good awareness very quickly. I think you'd agree. I think some of the replies would note a certain amount of controversy, especially perhaps from the teaching profession at the time. Have you got any advice for us as paediatricians on how to raise controversial issues on social media for not just a COVID thing, like whatever future controversies we will face, and how to raise those on Twitter and social media as a whole, and how to deal with the replies?
Thanks, Ben. Really, really interesting, and not something I've thought about a huge amount. So let me have a go. I find Twitter very scary, which is not something that people who follow me on Twitter might realize. I think the idea of writing quickly, pithily, and without nuance can be dangerous. And it's remarkable how the ones that you quickly dash off are the tweets that you quickly dash off are the ones that get the most views. So that's a bit concerning to me. And I'm constantly guarding against trying to get likes and retweets, which can be an aim of people on Twitter. So I know if I wanted to get likes and retweets, I know what to write. And I think that's a dangerous position to be in, I think, for me. So I'll talk about myself and then people can take what they want from it. But I find that dodgy, I think. And I want to speak as someone grounded in data and evidence as much as possible, whether there are data and whether there is evidence. Having said that, I found it a really important avenue through those early months, as you said, because there seemed to be a message that I felt needed to get out, and my work through what I would consider more conventional channels here in the region, but nationally through the college and so on, I just didn't feel we're gaining traction. So, or traction quickly enough. It's being recorded. So I felt that there was an urgency required, and so I was working with a broad coalition of people, and just decided to start speaking out and accept whatever consequences there were for my own career. Stephen still invited me to speak today, so it can't have gone that badly. And I ended up on the BBC, which was really, really surprising. And I think it was good. I think it almost opened up. It was really scary because I came off the BBC. They put me on a split screen with the head of the union leader at the last second. They'd also at the last second asked me my political affiliation and announced it to the whole country, including probably my parents, who didn't even really know about this thing. And so that was scary. And I came off, but I did notice in the weeks that followed, possibly not causal, possibly part of the same pathway, that there was a real paediatric lobby. And like I say, the seeing the college speak up for all of us was just brilliant.
Yeah, I think we're all very grateful for the issues that you raised during that time. So the good questions. Obviously, we've talked about what went perhaps badly during management. Were there any countries that did particularly well in terms of protecting child health and child education during the pandemic?
Well, education and child well-being, I think we could look to the Scandinavian countries. I think we could see that several of them, including Sweden, but not only Sweden, kept their schools open throughout. And the question that was asked, and I didn't show this paper, but there was a paper early on by Russell Weiner and colleagues asking the question: how much do school closures contribute to reduced COVID transmission and fighting against the pandemic? And in the end, we decided in this country that we had to close them. So did many countries, as you saw from the map around the world. But the question that I suppose that I would ask is, how much did it really contribute? And I think we would want to know that for the next pandemics, and hopefully Jimmy and others who are going to speak about the future will be able to enlighten us on some of these issues. Maybe these are PhDs for the next decade. But yeah, Scandinavia and allowing children to get on with their lives in some ways.
Yeah, a good question from Camille. It's obviously young children especially, largely unaffected, but obviously their parents and grandparents would be affected. So, and obviously there'd be a lot of children who had to deal with sick relatives or in bereavement within their families. Has there been any work to look at the impact of that on children's health and emotional well-being?
I think that's an important question that does come up, and I don't have a simple answer to it. Certainly not. I haven't seen any empirical evidence around the impact of grief and bereavement on child health and well-being, but as paediatricians, we all know that that's absolutely crucial and so important. I suppose, in a way, my current thinking, and everyone will have their own thoughts on this, is that maybe this is part of the resetting back to a child rights framework, because we don't ask these sorts of questions necessarily. Well, hold on, let me separate out. So, really important, and what's happened to our society in all sorts of ways, including to older people and grief and bereavement, is hugely important, full stop, end of story. There is a side question about transmission, which I'm not sure if that's exactly what Camille's getting at, but the question of, is it the child's fault if they get COVID-19 and take it back to their households and take it back to their older relatives? And I think our thinking from a child rights perspective will probably be useful in thinking about whose fault it is if somebody gets COVID-19. And I think there's a lot to be said on that topic, but I think for me, this idea is not something that I sign up to.
So I think it's just running out of time there. So I'm sure people can contact you on Twitter or similar to ask any other questions. So I'll just hand back to Stephen just to hand over for the break and the rejoining instructions after the break.